Don, you tell me when to corral them.
We'll give it 12:03. We'll give it.
All right, everyone, we're going to get started so that we can get out on time, because I understand everybody's got things to do starting at 1 o'clock. Welcome to Updates in Migraine Management and Primary Care. This is a Rockport CME event, and they sponsored, I suspect they sponsored the lunch, did they? They did not? Then forget it. Then it's just a Rockport CME Grand Rounds activity. You will have in front of you the participant survey and CME evaluation. It's in the front of your syllabus there, and there's also separate questions that you are really urged to fill out so that CME events like this can be sponsored in the future by Rockpoint. So if you could take a moment and kind of do the answers in real time, and then at the end spend a minute or two answering any of the post-test questions, that would be greatly appreciated. There's a whole bunch of pages in the one packet that shows who put these slides together. I was one of the Education Committee participants for that, as well as Dr. Jack Shim and two of my residents who also helped. This is was really designed as a resident initiative. And are there any residents here? Okay, good. All right. It's really targeted towards helping everyone identify patients with migraines, because I think it's something that we as primary care have trouble identifying at times. So that's really what we're talking about today. We're going to look not only at the epidemiology, but also the differential diagnosis and impact of migraine on a patient. We're going to talk a little bit about the role of calcitonin gene-related peptide. Has anybody heard of that or heard of the new medications that are out now, which is very exciting in the field of migraine? And we'll talk about both pharmacologic and non-pharmacologic management of migraine in both the preventive as well as acute setting. So here's your packets. This is your job now. Please rate your confidence in your ability to differentiate migraine from other types of headache. Not confident, slightly, confident, confident, highly confident, or expert. And if you're expert, please come on up and we can present together. I'm actually an internist. I have a resident clinic practice, and that's been my entire career. I've been doing that same job, teaching residents in a clinic at our hospital for, you say over 30 years, because that's code for boy, she's old, you know, but I've been doing it my entire career since residency. So when we just, a little bit of background, there, as we know, several types of headaches. The primary examples are headaches without any really known structural problem going on. Migraine, tension type, and cluster. And of course, today's focus is going to be on migraines. But we do need to be mindful of the secondary headaches, the infections, the space-occupying lesions, rheumatologic like giant cell arteritis or glaucoma, eye involvement, neurologic trigeminal neuralgia, idiopathic intracranial hypertension or pseudotumor cerebri, which we really see sometimes in sort of the same group. Often it's younger women, sometimes overweight, who present with headaches, and we really have to be good at doing a fundoscopic exam, and it's really something that I try and stress with my residents, to look at the eyes and see whether there's any papilledema that would be indicative of a pseudotumor, increased intracranial pressure that patient might have. Acute hypertension, and we're talking about really high blood pressures, you know, well over 200 systolic to give somebody a headache. 160, 170 is not really pressure that would contribute to headaches. So just one slide on the epidemiology. 1 in 5 U.S. adults has migraine, and actually this number should be updated. It's over 30 million. It's like 35, 38 million persons who have migraine each year in the U.S. Women more than men, 25% lifetime for women, 8% lifetime for men. But when you see someone, you want to say, well, is there a family history of a similar kind of headache? Because about 70% of migraineurs have a positive family history in a first-degree relative. So that's a good question to ask your patients when they come in with headaches. We have about 10 to 15 million visits between us in a primary care practice and into the emergency room that are attributed to migraines. And of course, the economic impact is not inconsequential as well. So let's look at a case. Here's Lizzie. She's coming in and she's asking you for help with her sinus headaches. She's been getting them for years now, but they're occurring almost daily at this point. They're predominantly frontal and maxillary, and they're not throbbing. She takes acetaminophen almost daily, along with pseudoephedrine and occasional loratadine, when she also has watery eyes and nasal congestion. So what else do we need to know about Lizzie? So first of all, don't go down the rabbit hole of, oh, this is a sinus headache, let me give you an intranasal steroid, right? You really have to step back and ask a few additional questions. So we have to go back to basics. Find out, and one of the most important questions that I find is, when did your headaches start? Sinusitis is an acute thing that's associated with fever and purulent nasal discharge. So somebody saying, I'm having trouble with my sinuses, you've really got to step back and think that this could be a migraine headache. So, you talk to Lizzie and she started getting them as a teen, and maybe they calmed down, and now she has kids and she's under stress and she has a new job, and they've kind of morphed, and they don't look like your classic migraine where you want to close your eyes and go into a dark room and not do anything. patients will at least try and function with these headaches, so they don't look like a rip-roaring classic migraine that we often think of. So we have to really look at somebody like this who comes into our practices, and I see this all the time. And either they have medication overuse, which Lizzie probably has, she's taking acetaminophen almost daily, or they have chronic migraine, and we're going to talk a little bit more about that in a minute. So with regard to the exam, of course you're going to, do a neurologic exam. I like to just look at their body language, especially when they come in with a spouse or significant other and they're looking at the floor and the other person's answering all the questions. I just think domestic abuse of some kind, and I think it's just something to have in the back of your mind. But you're going to palpate the head, the arteries, the trigger points. The other common area that patients will complain of is neck pain. So they don't look like your classic, you think oh my God, the migraine, unilateral pulsating and everything else. They just might come in with neck headaches that then spread all over. They might have trigger points in their neck. But I'm going to highlight performing a fundoscopic exam. So please try and do that if you can on a patient. And if you don't know how to do it, then maybe spend a half hour with your friendly ophthalmologist and try and get some good tips on how to do that. So episodic migraine, recognition by International Classification of Headache Disorders. I think we all are familiar with migraines. Migraine without aura, at least 5 attacks with at least 2 of the following: unilateral, pulsating. Why didn't that change? Let me see. Don, the computer isn't in presentation mode, so that's why this isn't following along with the clicking. I don't understand what's happening. But now I'll just look at this. Migraine without aura, 5 attacks, 2 unilateral, pulsating, moderate to severe, aggravated by or avoidance of routine physical activity, and at least 1 of the following: nausea and or vomiting, photo and phonophobia. Migraine with aura is the same thing, but on top of that, the patient may have a premonition, have either a visual, a sensory, or a speech or language dysfunction. Have any of you seen this video of a reporter? This was several years ago. She was reporting live, and she just started talking jibber jabber. It was very bizarre. And the announcers were saying, oh my, she's probably having a stroke, and she was taken to the emergency room. She was having a migraine with speech dysfunction, which fortunately should last less than 60 minutes. All of these things should last less than 60 minutes. But you could have more than 1 aura at a time, and that can be very disconcerting to a patient. But I mentioned chronic migraines, and on the same slide I've got medication overuse, because this is the type of patient that I usually see in my practice. I have a managed Medicaid self-pay patient practice, and the patients get desperate and they come to you and they say, I can't stand it anymore. And they're having headaches almost every day. So is it a migraine that has transformed into a daily headache, or is it that they're taking acetaminophen or ibuprofen or Excedrin almost every day to keep a headache from coming, or as soon as they have a headache, and they're having a headache almost every day? So the goal is to try and revert these patients back to having just an episodic migraine, or if we can, remove the offending medication overuse. Have them not use that, give them something else to use, and kind of go from there. So let's tease this out a little bit more. Again, because patients will present and it seems like, oh, I'm treating a tension headache, or I'm treating a sinus or a neck pain. You look at, and Don, this just, the mouse isn't working anymore because it's not in presentation mode.
Let me get Cat. That's not my computer. That's my computer.
Oh, okay. All right, I just don't understand why, because it did before. Well, anyway, if we look at the progression of different headaches, sometimes patients may only feel lousy. They feel like a headache is coming on, but they don't get a headache. Or they have an aura without a headache. Or they have a mild headache that looks tension type. So they can have a whole spectrum of headaches that are part of the migraine spectrum here. Then they can have a probable migraine and then an actual rip-roaring migraine. And here are the different levels of neurovascular activation and central sensitization. Central sensitization, did you ever have a patient say, God, when my headaches are so bad, I don't even want to comb my hair? That's central sensitization. It's a real thing. They don't want to wash their hair. They just don't want anything touching their head because they're so sensitized. And then this slide is the last, overview-ish kind of slide I want to show you, and that is how one can progress from episodic migraine to chronic migraine. So here you feel normal. You have mild impairment, moderate impairment, or severe impairment. And episodically, if a patient has a migraine 1, 2, 3 times a month, maybe even once or twice a week, you will have a headache and then you go back to normal. What happens though, you can transform that headache into a chronic migraine where you never feel normal anymore. Chronic is at least half of the days a month you feel lousy with a headache or a pre-headache. So this is how it looks. Episodically, you go back to normal baseline and then you transform as you become having headaches more commonly and more frequently. And you never get back to normal. You're always feeling mild or moderately impaired. So what does that do? It leads to medication overuse. It leads to sleep disorders and irritable bowel. And we have these patients who come in, oh gosh, God, she's always complaining of her irritable bowel and her headaches, and you'd rather trade that patient to somebody else if you can. It's because they feel lousy. They're not sleeping well. They've got this chronic migraine pattern, and they can get mood and anxiety disorders. So what you want to do is move these patients back and treat them with preventive medicines and treat them with appropriate medications so that we can then manage the headaches as they happen more individually. So that's the purpose of treating a migrainer. So here's another question for your packet there. The ID migraine screening tool evaluates for all of the following except associated nausea, vomiting, photophobia, sinus pain, limitation of work or activities, or they're all part of the ID migraine tool. What does everybody think? Are they all part of the tool? Okay, well, let's see. So here is the ID migraine tool. And actually, sinus pain is not part of that tool. Okay, so this is great. And how many of you see migraine patients on a regular or at least intermittent basis in your practices? Anybody? Okay, I've got 2 hands. More hands, 3, 4. Okay, you're chewing. That was okay. So, what do you use to identify a migrainer? Do you use ID migraine or do you use the pound mnemonic? The pound pulsatile and all that stuff. Do you use that one? See, that one's 5 questions. I like this one because it's 3 questions. So, choose yes or no. When you have a headache, do you feel nauseated or sick to your stomach? When you have a headache, does light bother you a lot more than when you don't have a headache? And then during the last 3 months, have your headaches limited your ability to work, study, or do what you needed to do? 2 out of 3 yeses in a primary care setting has a 93% predictive value of it being a migraine headache. So easy, 3 questions, and it doesn't have to be every single headache. That's another important point. You know, they might not feel nauseous with every headache, but if they have headaches that give them nausea, then they likely have migraines, and some of the other headaches are a different part of that same migraine spectrum. Which of the following is not an alarm sign in patients with possible migraine? And I'll let you read this and answer, and maybe you can even shout out. Which one don't you think is an alarm sign? What do you think? So it's actually 4. So if you have a history of cancer, could you have a metastasis? So that's why history of cancer is a little bit of an alarm sign. So here are the indications for diagnostic testing. And there's a mnemonic called SNOOP. And you look at systemic symptoms, fever, weight loss, secondary risk factors like HIV or cancer, neurologic signs or symptoms, new onset, that new split-second worst headache of my life, could they have a brain bleed kind of thing. That's an alarm sign. Older, especially over the age of 50, migraines present generally in a younger person. Now, they might go away for years and then come back depending on stress and other factors in an older patient. But I'll always ask for what is their history of headache. But somebody who says, I have never had a headache a day in my life and now I'm getting them every day and they're 53, you've got to evaluate that. So diagnostic testing is indicated if any of these red flags are present. There's a couple other P's: pattern change, papilledema, postural hypotension. Things like that are also part of this question that we should be asking our patients. But we have green flags: stable pattern for 6 months or more, long-standing headache history, a family history, as I said, over 70% will have a first-degree relative with a migraine, a consistently normal exam, and maybe a consistent trigger like weather. And you think weather, oh, it must be a sinus problem. No, weather can trigger a migraine. So that's a very important point. But diagnostic testing is not indicated if only green flags are present. If indicated, which test to do is always a big question, and really you don't want to do a test if they meet criteria for migraine. So choosing wisely tells us not to perform neuroimaging studies in patients with stable headaches that meet these criteria. So going back to Lizzie, she used to have the more common migraines, occasionally, once or twice a week. As a teen, but they evolved into these less intense, almost daily headaches. And in 2 studies, 86 to 88% of patients who self-diagnosed as sinus headaches actually met criteria for migraine or probable migraine. So that's why that's such an important point as you see your next patient who comes in saying, oh, I have sinus headaches. You really have to delve into whether it's migraine. So based on a diary review, 94% of headaches that prompt a visit to a PCP are migraine type. So what does that mean? Somebody who has tension type headaches generally is not going to take off from work and schedule an appointment to see you. It's somebody who has these worse headaches who's going to do that. And if they fall into that category, they're 94% of the time, they're going to be a migraine patient. So those are the key takeaways, and I'm going to move forward with current approaches to management. And first, we're going to look at another case. So Ricky, He's a 31-year-old CPA, and he had occasional migraines since his early 20s. He would take naproxen and or a triptan, and that worked for him. But he started a new job 6 months ago requiring him to work long hours. His headaches have increased now, and they occur several days a week, especially on weekend days for the last few months. And he's now taking abortive. He's taking his naproxen and or a triptan most days a week, especially on weekends. So you have to step back and say, well, why would Ricky's headaches change? He's got stress because he's got a new job, right? But the other thing he's probably doing is, and I'm going to move forward to the behavioral strategies here. He's probably sleeping 5 hours a night during the week because he's really got a new job. He's trying to make an impression. And then on the weekend, what is he doing? He's sleeping in. So patients need to sleep 6 to 8 hours and be consistent with 1 hour to bed to rise, even on weekends. Migraineurs, wiring, whatever, it's a little bit more sensitive to changes, to stress, to triggers than someone who doesn't have migraines. 100% of us in the room here could develop a migraine if the circumstances were correct. If you were hungry and you had bright lights, I love that this light here is blocked, which is, it's great. But you know, hunger, lack of sleep, bright lights, loud noises, perfumes, you get that perfect storm, any of you could have a migraine. But migraineurs, it doesn't take that much. So they really have to look at, you know, their life and be mindful of some things that could be their triggers. Exercise, everybody should be exercising. Stress management, of course, we all need that. Decrease substance use. I love this one. Taper caffeine to a maximum 1 6-ounce cup. That's not 16 ounces. That's a 1 6-ounce cup of coffee. Okay. Eliminate artificial sweeteners. Some people don't realize they're putting like 2 or 3 packets of the artificial sweetener in every time they're having their cup of coffee, and it could be the sweetener that's triggering their headache. Eating fresh, non-processed, small, frequent, healthy meals and snacks. And having the patient keep a headache diary can help identify these triggers. So I'm going to go back and just talk a little bit about, we have to educate the patients, and this takes time. There are acute treatments that we can give a patient, and we'll go over those. And Ricky's already taken. He's taking an NSAID, and he's taking a triptan. I like to highlight the fact that we need to start preventive medicines much earlier than most of us offer our patients. And then there are lots of non-pharmacologic behavioral neuromodulation and complementary alternative treatments, and I'll go through them as we go along. But we have to be realistic with the patient. Establish realistic expectations. We're not going to get rid of all their headaches, right? So we should get about a 50% reduction with prevention, and we'll go through those meds. Now that may be higher with these newer monoclonal antibodies I'll talk to you about in a second. And we should be able to find the right combination of acute treatment management for our patients. But it takes tweaking. It takes seeing the patients back. I always love it, like the neurologist will see somebody once and they'll say, I'll see her in 6 months or see you in a year. Well, you know, that patient needs more, you know, dose adjustments over time. So that's really up to us to help our patients feel better. The patient has to accept that some treatment side effects are inevitable. Now, these may be much less with the new monoclonal antibodies. That's true. But, you know, we know that propranolol, or we know that, like for example, amitriptyline. I always love it when I get somebody who has an agenda, and we all know, we've all had the patients who've had the agenda, right? Well, you know, the only thing that works for me, doc, is either Fioricet or that D one. I think it's dilaudid. I got it in the emergency room a couple times. I'm like, well, that's fine. You can find somebody else, okay? Dry mouth with amitriptyline, or a little tiny bit of fatigue with the beta blocker, or problems with the topiramate. They all have a trouble with everything that you're trying. They're more difficult. I say, okay, well, dry mouth or migraine headache. The dry mouth must be way worse than the headache you're having, right? So you have to kind of get them to understand that they're going to have some treatment side effects. You really have to adjust the dose. Start low, build up slowly. So the acute medicines we've kind of covered a little bit. Ricky was on an NSAID already. There are combination analgesics. I don't use steroids unless they come in and they've had a headache for 3 or 4 days and nothing is taking the headache away. I will give some steroids for a couple of days to break that headache. That's the only time. I've only done it a few times. These are non-specific medicines because they could be used for anything. NSAIDs could be used for knee pain. The specific ones, triptans, are my go-to one. I don't tend to use dihydroergotamine products in my practice, but they are available for migraine treatments. There are new formulations of the same old stuff. There's different ways to breathe them in, like the sumatriptan powder, and there are new formulations in development. And we're going to focus on the Gepants and the lasmiditan, which have really some very good data, not FDA approved as yet. We're not to use over-the-counter meds too often for our patients. And in general, if you think about it, the patients are already coming in and they've already used 2 or 3 bottles of the Excedrin or the Motrin. So they've already tried the NSAIDs. They didn't work. They decided they had to take off from work and make an appointment with you. Which of the following suggests the patient should start a preventive strategy? 9 or more headaches per month, symptoms interfere with daily life, use of acute meds more than 2 times per week, patient request, or all of the above. What do you think of this one? All of the above. So our goals for initiating migraine prevention include all of those reasons. And we want to reduce disability and we want to reduce medication overuse. I really don't want people taking abortive medicines more than 8 or 9 days per month. So that's my goal. And unfortunately, again, by the time I see patients in my practice, they're already taking stuff 4, 5, 6 times a week. How long should you advise a patient it might take for a preventive medicine to be fully effective? What do you think? A week, 2 weeks, a month, 2 to 3 months, or 6 months? Like if you use a prevention. And first we have to talk about prevention, but in general, what do you think? It's going to take about 2 to 3 months for a full effect of a medicine like propranolol, like topiramate. So these are the oral preventive therapies for episodic migraines before these new injection medicines came out. And they're still our go-to. We still need to use these meds for our patients. And then if they fail these medicines, they can then hopefully qualify for some of the medicines I'm going to be telling you about in a minute. So there are some with established efficacy, like the valproate, topiramate. I'm a topiramate one that I'll reach, that's the one I'll reach for. For the beta blockers, I'll reach for propranolol or metoprolol. Now the triptans, this is tricky. This is only for menstrually related migraine. You don't want to have somebody take a triptan as a prevention every day, right? But let's say somebody knows that they get a migraine headache 3 days before their period or the day their period starts. They would start the triptan and take it for 3 or 4 days to keep that headache from happening in the first place. Level B, probably effective, antidepressants and the tricyclics or the SNRIs. I tend to use more amitriptyline, but if they have too many side effects with that, you can use venlafaxine. There are other beta blockers listed in this category. Nadolol, I find sometimes the headache specialists like to use, but I don't think it offers anything over the level A, propranolol or metoprolol. Level C, I don't go down to these that often. I'll really start with one of these as my main framework, but the big thing is you start low and go slow. I'm going to point out something that's missing here, a medicine that a lot of times people think is indicated for migraines, verapamil. You don't use verapamil for migraine. Now you can use it for cluster, and it used to be used like 10, 15, 20 years ago for migraine, but it really doesn't have good data. So don't reach for verapamil. Try and reach for something with the level A or B efficacy. The first approved treatment for chronic migraine was onabotulinum toxin A, which involves 31 injection sites into the head and neck every 3 months. Interestingly, onabotulinum toxin blocks the release of calcitonin gene-related peptide, which is what we're going to talk about now. So the key takeaways: don't have a patient take an abortive medicine more than 2, tops 3 times a week. You want to have them on a prevention medicine to cut down on the number of headaches so that the abortive can work more successfully. Now, just looking at Maria, she's 38. She's actually doing everything you've told her to. Now, the chance of a patient continuing on a prevention medicine after a year is actually pretty low. They're not on the propranolol that, for a year or two. They're not taking the topiramate. But she's adherent. She's taking topiramate 50 BID, and she's using her triptan as needed. But just despite this, in the last 3 months, her headaches have increased from 1 time a week to 3 to 4 times a week. Despite doing everything right, she's avoiding triggers when she can, and headaches aren't always being relieved by the triptan. It happens. So given her worsening migraine pattern, what's the appropriate next step here? A calcitonin gene-related peptide inhibitor, gabapentin, clonazepam, or lamotrigine? What do you think? I'll give you a clue. I keep talking about this one, okay? And it's the longest answer, right? So, I'm not going to give you a lot of pathophysiology. I'm an internist, but here's the point of this slide. CGRP, calcitonin gene-related peptide, actually acts externally on the trigeminal vascular system and then is also released in the brain. So it's released external to the brain as well as internal to the brain. And that's just shown here. There's all different sites that have expression of this calcitonin gene-related peptide. And if you infuse this, if you have a friend with migraine and you want to be really cruel, if you infuse calcitonin gene-related peptide into them, you'll trigger a migraine. So blocking this was a target of treatment, and it's been a target for a couple of decades. It's just that they had to refine these agents so that they wouldn't create other problems like liver toxicity. So CGRP is a potent vasodilator of cerebral arteries. And serum levels are elevated in chronic migraine. I already told you if you infuse it, it's going to create a migraine. There are small CGRP receptor antagonists called the GPANTs that generally are being designed for abortive therapy. And there are large molecule anti-CGRP or anti-CGRP receptor monoclonal antibodies. And we know there's monoclonal antibodies for other diseases, you know, for rheumatoid arthritis or ulcerative colitis, all this stuff, monoclonal antibodies, okay? Because of their large size, these antibodies aren't going to be crossing the blood-brain barrier, so they must be working peripherally. That's the theory. Well, here are the GPANTs, and I won't spend a lot of time on the GPANTs because they're not FDA approved yet. But the early ones the development had to be stopped because of liver toxicity. So these are the newer ones that are in phase 2 and 3 development for acute treatment. And actually they're looking at giving them daily for prevention. Well, let's just look very briefly at the slide for rimegepant and ubrogepant, which are the two closest to being approved, where you would take it as an abortive. And here in blue is pain freedom at 2 hours post-dose compared to placebo, and freedom from the most bothersome symptom is also shown here, and you're significantly different from placebo. Now, what's the most bothersome symptom? You know what? Some migraineurs, headache isn't the worst thing that they have. They feel lack of concentration, or they feel lousy, or they're nauseous. So agents not only take away the pain, but they also take away the most bothersome symptom other than pain. Ubrogepant, same deal. You can see in the maroon, 2 different doses compared to placebo. You're having better results with ubrogepant there. Well, the ones that have hit the market are the monoclonal antibodies to either CGRP or the CGRP receptor. And these are indicated to prevent migraines. And this just shows you, here's like a GPANT. Here's a small molecule. It's like a flea on an elephant, I'm told. Like these molecules are giant, so they're not going to cross the blood-brain barrier. So they're working peripherally. They're working in the entire system. So they don't seem to have any hepatotoxicity, and they have a very quick onset. Some will separate in the clinical trials from placebo. You give a sub-Q injection monthly, or one of them's monthly or every 3 months. You give a sub-Q injection, and after a week, you're already seeing a difference compared to placebo. The responder rate is 75% or more. Safety and tolerability, similar to placebo, and they decrease acute medication use. So they're cutting down on the need for that patient to take that naproxen or ibuprofen or triptan. There are 4. 3 are approved, and they're kind of in order of their approval are listed across here: arenimab, fremanezumab, and galcanezumab. Eptinezumab is going to be IV. These are sub-Q, these 3, and they're indicated for episodic or chronic migraine, and fremanezumab also, and galcanezumab for episodic cluster headache, as well as episodic migraine and chronic migraine. They're generally given once a month, as I say. The one is given either monthly, or this fremanezumab is given either monthly or sub-Q every 3 months. But the effect is similar no matter how you give it. And this is all on one slide, the 3 of them, because you can see how they separate from placebo in chronic migraines. So these are patients who've had 15 or more headaches a month, and within a month, you can see a significant benefit after one injection for all three of these medications. Now, for episodic migraines, so these are patients who have less than 15 headaches a month, you're seeing the same effect. You're seeing actually pretty much mirror images. They're often studied with 2 different doses, and you can see the benefit of the 2 different doses of the 4 different medications compared to the black placebo line down here. This one was blue placebo. Actually pretty impressive reduction. So how can we get these to our patients? And there are AHS consensus guidelines to tell us how to do this, because you're not going to be able to get this. You have a migraine patient who comes in, you still have to tell them to try the prevention medicines I told you if they need it. They can go with a triptan, and if they're having headaches too frequently that you don't want them to take a triptan more than twice a week, then you put them on a prevention, whether it be topiramate or propranolol or amitriptyline or whatever, okay? And then if they fail that, if they were having episodic migraines, lack of success with 2 antiepileptics, either valproate, topiramate, tricyclics, beta blockers, or SNRIs. So you have to fail 2 out of these categories, okay? And you have to have it that they're documented at least moderate disability or impact. They need to take off from work when they have a headache because they feel that lousy, or they have a job where they can't function. They're, climbing ladders or doing whatever that's not safe for them. So you have to document the disability. If they have high-frequency episodic migraines, 8 to 14 days a month. This was 4 to 7. Same requirements, but you don't have to document disability because they're pretty disabled. And then chronic migraine, same as this, but the other thing, remember, we said onabotulinum toxin. If they failed that and one other thing up here, then you can apply to get these things prior authed. Lasmiditan is a serotonin agonist. This was the other agent in development. Now, a triptan, they're great drugs, but they cause vasoconstriction. So you can't use it in somebody whose pressure's a little bit high, or if they have a history of coronary disease. So triptans work to vasoconstrict. They work on the 1B and 1D. I didn't know which one was B and D. So 1B and 1D here, okay? But lasmiditan, it works over here on the 1F. So lasmiditan only works centrally, not peripherally on the vessels peripherally. So it's a centrally acting serotonin 5-HT1F as opposed to triptans, which are the 1B or 1D. So no vasoconstriction here. So this is submitted to the FDA, and so the FDA is reviewing this. You can see that patients compared to placebo here are pain-free at the 2 different doses. Actually, there were 3 different in this trial. I wasn't, that Samurai and Spartan, and apparently those trial names don't really mean anything. It's not like you took the first letter of the trial name, but Samurai and Spartan, they thought it was a good, strong name. But you can see that you're having percentage of patients who are pain-free at 2 hours is significantly greater with the active lasmiditan compared to placebo. Now, it's a centrally acting agent, so some of the side effects are going to be more centrally acting with this. So just so you know, you've got more dizziness and vertigo. But what's interesting is the patients who experienced the dizziness and vertigo, they had really significant pain relief, so they didn't mind having a little dizziness and vertigo, apparently in the clinical trials. But it is important to know that this can happen. So there's a lot going on in migraines. This is really a very exciting time to be taking care of patients with migraine headaches. And there's just a couple more things to review. And I'm just going to highlight, because I know we want to finish right at 1 o'clock, but Sophia, or Sophie, she's 55, and she now wants to embrace a clean, healthy lifestyle. She has coronary disease. She's had migraines for 20 years. She's exercising now. She's sleeping regularly, but she's still having headaches 5 times a month. And she wants to know, well, I don't want to take a triptan. I don't want to take medicine. I don't want it. I want something else. What can you offer her to help reduce her migraines? So there's a whole class of medicine, or devices, actually. Neuromodulation for headache. Have any of you heard of these? Okay. So neuromodulators, there are 4 that have been FDA approved. So this one is this external trigeminal stimulation, and it's looked differently in the past. It used to look more like a tiara, but now you just paste it on your forehead. The problem with any of these is it's not generally covered by insurance. So if I recommend one to my patients, I tend to recommend this one to start with, because it could be like $550 to use it. It can be used acutely, or it could be used daily to prevent the migraine. And you have 60 days to try it out. And if it doesn't seem to float your boat, you send it back and you get your money back. So that, to me, is the one I tend to recommend. There's the single pulse transcranial magnetic stimulation, the STMS, as opposed to the ETMS. And this one you have to rent for $220 a month. So if it works, great, and that's probably the cost of some medications, or it saves the patient from having to take a vacation day from work and use that as a day to lie in bed with the lights off. But this is also approved for acute and preventive migraine treatment. The 2 other ones are a non-invasive vagal nerve stimulator here, and this one just came out last month, a remote electrical neuromodulation. And you wear this one on your vagal nerve, but it's it's not going to make you pass out. It's working on the different pathway. And this one you wear on your arm, and it's controlled through a smartphone. So I told you what my practice is, and a lot of my patients can't afford these agents. So I tend to go with some additional avenues. I give everybody 400 of riboflavin. I give everyone magnesium, and I've also learned to give everyone coenzyme Q10. So that's my more recent addition. It's because I can get these medicines covered. I tell them it's like a vitamin supplement for them, and 400 of each of these. And I believe the coenzyme was 200, but I have to always look that one up because I'm not as used to that one. Acupuncture has data, but it's not usually covered. But it has data. Osteopathic manipulation. Does there happen to be any DO schools or anybody around here that do osteopathic? Osteopathic cranial therapy, great stuff for this in a, quote, no pun intended, head-to-head trial with amitriptyline. Actually, cranial therapy, osteopathic manipulation was found to be as good or better and with fewer side effects. Exercise, yoga, Tai Chi, everybody should be doing that. Melatonin, 3 milligrams HS has been shown to be helpful in some trials. Cold therapy, slap in an ice bag. If you're starting to feel a headache, you might be able to abort the headache by cold therapy. There's not as much data on this, but if a patient can abort a headache or two a month that way, yay for them. Massage, homeopathy, massage, working on the neck, working on perhaps some trigger points. So it's really an exciting time, as I said, in our treatment of migraine because we now have so many new things. For years, we've been struggling with how do we treat migraineurs, and we have to use medicines that were designed for other reasons. So we have new classes, we have new devices. The monoclonal antibodies are specific for migraine. They're given monthly or quarterly. They have very few, if any, side effects. And I will highlight that if you have somebody who you might want to try and get qualified for the monoclonal antibodies, document their failure of different medications so that if you get to that stage or you send them to a neurologist to try and get those medications, you have documentation of what they tried, how it didn't work, and so forth, so that they might end up getting their insurance to qualify. So this is a Residency Connect. This was to be a co-presentation with a resident, but there are, if you want to hear this lecture, there's a slightly older version of this lecture at this website here, and that's probably also listed. The only thing I would really urge you to do, please, is to fill out the post-activity survey on the paperwork that's in front of you that you've been kind of kindly doing all along. It really helps Rockpoint, and it helps them get grants, further grants, so that you can get programs like this. So I'm going to close it here and see if there are any questions. Thank you. And I finished at 12:59. Yes?
What form of magnesium do you recommend?
Well, the studies had magnesium triphosphate, but I tend to go with what I can usually get the patient, and I just tell them that it's possible their bowels may get a little loose. But most of them don't seem to have a problem. You give them some magnesium 400 and a little amitriptyline, and you probably balance off the triphosphate or a phosphate formulation of magnesium. I've seen you can get online. But again, most of my patients don't tend to buy anything that they're not going to have their Medicaid insurance cover. Any other questions? All right, thank you.